Good evening, everyone. Thank you for joining us this evening. My name is Rachel Green. I'm part of the leadership team here with Women of Color Coalition. And tonight, this is another installment in our series of our State of Women of Color of the United States, what's happening around in the nation. As you all know, we're all dealing with so many different issues. And tonight, we have three fabulous leading doctors out of the state of New Jersey that are here with us this evening to speak to us about our bodies and what's going on with Black maternal health. First, we have Dr. Pamela Brug. Dr. Brug is a board-certified obstetrician, gynecologist, and affiliated with the Hackensack Meridian Health Mediterranean-based Medical Center. She is also a founder of the New Jersey Black Women's Physicians Association. Dr. Brug, do you mind giving everyone a little wave? Wonderful. And next we have, and doctor, please correct me if I get the pronunciation wrong. Do not hesitate to jump in and correct me, please. But next we have Dr. Ndeye. Correct me, sister.
Ndeye-Aicha Gueye. It's Ndeye-Aicha Gueye.
Thank you so much, Ndeye. Ndeye is a board-certified obstetrician and gynecologist at the Reproductive Medicine Associates of Lehigh Valley in Pennsylvania. She is also of the Association of Physicians with Gynecology and Obstetrics. As well as we also have with us this evening is Dr. Charletta Ayers. Dr. Ayers is an associate professor of the Department of Obstetrics and Gynecology and Reproductive Science at Rutgers University at the Roberts Wood Johnson Medical School. And these ladies, ladies, their resumes are so diverse. And as we're talking with them, these ladies are going to jump in. Not only are they going to give you ladies some great information and facts tonight, but also ladies, if you don't mind, if you can throw a little nuggets of who you are and a little bit of your background in there as well, as you answer our questions for us tonight. I know I'm looking forward to being further educated, and I know those that are joining in are as well. I will now hand the mic over to my co-host with me tonight, Ms. Lynn Halliburton. Lynn?
Hi, I'm the Director of Communications for Women of Color, and thank you everyone for being here with us. It means a whole lot that we have all of everyone's support. So we're going to start off with our first topic, which is Black maternal health. And you know, when we decided to do a series on tonight's topic of Black maternal health, Rachel approached me with the idea, and it got me to thinking about my own life and the women in my family and friends who have had complicated histories with their maternal health, and some who have even unfortunately died as a result from pregnancy complications. So when I was doing research on this topic, I found out that on the CDC website, it says that Black women are 3 times more likely to die from a pregnancy-related cause than white women. Having experienced this issue with women in my own family, there is a natural healthy skepticism that our maternal health will be valued by a healthcare provider, because frankly, we're dealing with this sort of generational trauma that comes with seeing women in our own family deal with this issue. So my first question for the ladies, and we can start off with Dr. Gueye, is, how should a Black woman approach the process of choosing a healthcare provider who will listen to her unique medical needs and ease any concerns or worries that she's might be experiencing, or if she's experiencing discrimination and or medical neglect from a doctor? Dr. Gueye.
Hi, thank you very much for having me here, ladies. So I'm actually an infertility specialist. So I help couples who have difficulty getting pregnant, get pregnant. And so in my specialty, the way that you pick a doctor is based on you know, who has the best pregnancy rates, essentially, like what lab is doing really well in helping couples get pregnant. And so it's really important to know that based on the specialty that you're picking, who is the best doctor for you based on the needs that you have. Okay. So if you already have a diagnosis, you already know, you know, what your issues are, then looking for a doctor who's specialized in that topic is going to be key, because you know that they're going to be sort of really in tune with your disease and be able to care for you to the best of their abilities. That's not always the case. But if you are going, if you pick a doctor, you have to decide if this relationship, this patient-physician relationship, is working for you. And so the way to be really prepared or to understand whether the relationship works for you or not is you have to come prepared, come with the questions that you have. Most doctors don't have that much time to sit and talk about all of the issues you may have. So you have to be prepared to talk about the ones that are the most important to you and make sure they get addressed. You have to take notes and bring notes. Sometimes you have to write these questions down so you don't forget them. You can bring a family member with you or a friend with you so that if you forget to ask something, they do, or if you didn't catch all the information that was provided to you, your family member or friend is able to remember and help you. The other things are, if you don't understand what your doctor is saying, ask, say it again. I don't understand. Please explain, you know, and don't be afraid to say that, because that's their job. If you don't understand the care that they're trying to provide or the testing that they want to do, then nobody's winning, you know, you're not understanding each other. And this communication between the doctor and the patient is going to be crucial in building a relationship that is trustworthy. If you don't trust your doctor, then you may not be compliant to the recommendations that they have for you, right? And if you feel like you're in a situation where you feel like there's some discrimination, you may not be getting the whole story, and basically you don't have trust in your physician, it's time to find a new physician or at least get a second opinion. And so those are the things I would say. Also talk to other people who may have a similar situation as you. If you have fibroids, there are lots of Black women, of course, who have fibroids. It's 80% of our population. Talk to them about their experience or explain your experience, and that may also help somebody else's experience. So I think those are certain things that you should think about when choosing a doctor and when you have a doctor, to determine, do you like this doctor and is this relationship working for you?
Right. And Dr. Brug, what's a great way for someone, you know, who has that skepticism towards the medical industry, you know, how should they, you know, take that first step to get the healthcare that they need?
I think the main thing is talking to either family members or friends, acquaintances, could be also colleagues at work, to see who they would recommend. And usually when you have those type of conversations openly, you will find out that people will have like a common person, like you'll hear Dr. X from like X amount of people. And then you're like, okay, maybe Dr. X will work for me. And then, you know, it's almost like a consumer rating, right? And that's how I would treat it. The people around you probably have a wealth of information, and they will let you know. And if you give up Dr. Y and people have had a bad experience, they will definitely let you know. So I think that's the way to start off. And then I agree with Dr. Gueye in regards to going. It's, you know, the first couple of times you go to the doctor, it's almost like you're interviewing them, right? It's you're establishing a relationship with someone who could be your physician lifelong, right? How does that person respond to you? Do they listen to you? Are they addressing your concerns? You know, and then really, if they're not, find someone else. And and I say that with a caveat. In New Jersey, in certain parts of New Jersey, that may be easy to do, but in certain parts of New Jersey, it's not, right? There are OB deserts in New Jersey, meaning that it's very hard to find an OBGYN or find a physician who is delivering babies still. So you may have to travel,
Mhm.
which is unfortunate. And we have that happening all around the country.
Right. And Dr. Ayers, in my research, I was reading that, a lot of times Black women, they see a physician, but the symptoms that the Black woman is experiencing is not being taken seriously. So what should someone do in that instance? Should they choose a new healthcare provider? Should they keep seeing the same provider? If they're experiencing something that the doctor is not recognizing as a health issue. You're muted.
First, I want to thank all of you for inviting me. And I think that's a very good question, because that's a question that is very important. As women in the literature, we know that women are the #1 advocates of obtaining health care for their entire family. And I want them, and most of the time they're searching for healthcare providers for their children, for their parents, for their partners, and they wouldn't tolerate that for other individuals in the family. And I think this is time too to say that same type of initiative, that same type of going and getting information about individuals for their family members is the same way they should do for their own health care. And I think as Black women, sometimes we don't take that same initiative for ourselves. And I think this is one time our health is very, very important for a multitude of reasons, because we are caring for the rest of our family. And if we aren't healthy ourselves, we can't care for others. The other part that I think is important is similar to what Dr. Gueye has stated, is communication. And I think one of the things is knowing what your communication style is, and making sure that that communication style is similar or can be consistent with your healthcare provider. And also advocating for yourself. Sometimes a healthcare provider, in all honesty, may be believing they're answering your questions. But if they're not, I think we have to advocate and say, doctor, I'm sorry. My question really isn't answered. I know you shared that with me, but I'm concerned about A, B, and C. And I think that's where Dr. Brug and Dr. Gueye saying, come in with your questions, because sometimes we forget. As we're going in, we get nervous sometimes. We're not quite sure if all of our questions get answered. And I think the other, especially when it's an important health condition, is always have another set of ears being with you, having someone else come with you. And I think that's very helpful. However, since COVID and the pandemic, that's been very, very difficult. And all three of us have seen that in our practices, that because we haven't been able to have family members come in because of COVID and only the patient is able to come in, it's been very difficult to have sometimes those in-depth conversations with the entire network of that individual's network who support them. And so we've been using telehealth to have that other member there if they can't come in the office at the same time. Getting on the phone, asking your doctor, can my significant other be on the phone at the same time you're describing this procedure you want to do? So I think advocating and communicating is really necessary. And if all things fail, you need to find another provider. You should not feel as though you have to stay. And getting second opinions, most physicians, if they have an issue with you getting a second opinion, that's a warning sign, because most of us always want you to have as much information as possible. So if a patient says, I want to get a second opinion of that, I welcome that, because maybe the way I communicated is not enough and someone else can reinforce what I said in a different way, because ultimately the most important part is the patient.
That's such a great point. The key is to practice that persistence. Like if you're not getting your questions answered, keep asking them. And I'll just throw this question out to the three doctors that we have on the panel. Does the gender of the doctor make a difference in maybe, issues that are pertaining to women's health care needs being answered? Does that make a difference at all? Anyone can answer.
I don't think so. I think that it is more important that you need the person who is empathetic or the person that is listening to you. So there, and in our field it's very hard. most most of the physicians at this point are female. But I think that one of the things, the key is the not actually what we teach in medical school, right? Are things that come that you are taught as a human being, probably from your family, in regards to how to treat other people, treat them with respect, listen to them, be kind. Those are not things we're taught in medical schools. Those are things that we already come in with in medical school. And so I don't think necessarily the gender makes a difference, but the understanding of your problems may be in some way easier based on your gender, just like we say about race, right? It is, you don't have to explain when you say, oh, you walk in a store and you just don't feel comfortable because somebody's following you. You don't have to explain that scenario or whatever other scenario, right? When you're talking from a Black person to a Black person. So the same thing can be said from woman to woman. Is some things you just don't have to explain.
I agree with Dr. Brug. I think gender is not so much of the importance. I think one of the is listening skills, being empathetic, and the awareness of individuals are different. And so listening to that individual to see what is important to them. And that's part of what we are taught regarding patient-centered care, is the empathy, understanding that, we all come from different walks of life, but we also need to listen to the patient regarding what their concerns are and what is important to them.
So true. Rachel?
Wonderful. Thank you for that, doctors. Our second question we had for you tonight was, according to the National Institute of Health, national severe mortality, maternal mortality rates have nearly doubled over the past decade. And the incidences of SMM was 166% higher for Black women than white women from 2015 through 2016. Can you explain what an doula is and how they may help a new mother today in 2021 and beyond?
Well, that's a really good question, because in 2018, a report came out regarding maternal mortality, especially in women of color. And we know that Black women have 2 to 3 times more risk of maternal mortality than white women. And when we did that evaluation, it was like, what's going on? What is happening? You also need to know our state of New Jersey is 35th. Out of all the states regarding maternal mortality. So we've really been looking at this from a statewide issue as well. And one of the things that was very prominent is by us knowing that some of this is based on racism, institutional racism, lack of more implicit bias that's occurring within our healthcare system. And so when that was discussed, we know that this is a multidisciplinary issue. It's a public health crisis, really. So you have to look at it multiple ways. And one of the ways that was looked at is how can we do better? So they looked at how we can look at our institutions by teaching implicit bias for healthcare providers. They looked at different ways of what policies we're looking at. Why are we not getting, like in Europe, they give women postpartum a whole year of maternity care, where sometimes women can't even get their 6 to 8 weeks after they deliver. Are they getting enough access to different things? So the idea came of doulas. They did research actually looking at doulas and saw that in certain areas, when doulas were part of the healthcare team, those individuals did much better, had better maternal outcomes than women who did not, especially in the area of Medicaid patients. And so that came with the issue of doula. And a lot of individuals haven't heard of what a doula is, because it is not it's something that has been there for a long time, but a lot of people haven't had access to it. So a doula is actually an individual who advocates and supports women who are pregnant. And these individuals are not healthcare providers. They're not given there. They're more of community healthcare workers who are actually members of the community who are interested in supporting and advocating for pregnant women. So they advocate for them before they deliver prenatally by giving support, giving education, giving them, encouraging them to have access to certain things that they need during their pregnancy. They also support during labor. They support them in regarding their wishes for pain control, also advocating for them while they're in the hospital to be another voice and ears while that woman is there along with their partners. They also support them after delivery. And we know there's research showing that when you have someone who is supporting you after delivery in a support network, that you have decreased risk of postpartum depression and anxiety. So they saw that by having those individuals supporting them, they also help support their overall needs during pregnancy. So one of the things the state of New Jersey is doing is looking at doulas being a part of the healthcare team and actually having them being paid in that aspect for certain individuals to be a part of it.
Wonderful. Wow. Thank you for that. Dr. Brug, Dr. Ndeye-Aicha, did you ladies want to chime in any on that?
No, I just wanted to say, I think sometimes people get confused between a doula and a midwife, right? A doula is not a clinical person. It's like Dr. Ayers said, they're not healthcare workers. A midwife tends to be a RN, okay, a nurse, who then goes on to further training and education to be able to manage a pregnancy and also do deliveries and also then take care of women after they have delivered in the non-high risk individual. So I think it's important that people understand the differences between the two. One is there for support, right? And the other one is actually there for the care of the woman. I think that's very important.
Oh, definitely, definitely a very important distinction. Lynn, I was thinking before we go to the next question, I would love to give the doctors the opportunity to actually tell us a little more about themselves and their backgrounds that they might want to tell everyone tonight. And everyone, I apologize, I'm a little off tonight. I'm not feeling too good. I actually saw the doctor earlier today myself, so I'm not as sharp as I usually am, but we're gonna, because this is important. It's an important topic, and these ladies are absolutely fantabulous. And their message and their knowledge and information you all must receive tonight, because I know we're going to be helping somebody tonight. So, you know, ladies, if you don't mind, one of you just jump in, tell us who you are, your background, let everybody know these fabulous three ladies that we have with us tonight. Guys, when you hear their background, my goodness, we have gems with us tonight. Helping us in understanding this process.
So I can start. I am actually currently in Pennsylvania, but I was raised in New Jersey, and I actually trained under Dr. Ayers and Dr. Brug. They were my mentors. So they whipped me into shape, literally, and I'm alive to tell the tale. But so I did residency at Rutgers with them, and then I moved forward with fellowship to be a specialist in infertility. So right now I don't deliver babies, but what I do is help the 1 in 8 couples who have trouble conceiving. And so I help women just decipher what is wrong that is making it difficult for them to get pregnant. I do tests on them, and we offer them treatments in order for them to help them build their families. And so my practice is based in New Jersey, but I am physically in Lehigh Valley, Allentown, Pennsylvania. So my focus really, and what I want to implore on anyone here is, even before we're pregnant, and even before we talk about all the risks of morbidity and mortality in pregnancy, it is not easy for everyone to get pregnant. And some of these morbidities are preventing us from getting pregnant. And so when you're planning a pregnancy, it really should be planned. And when you're planning the pregnancy, you should be the best version of yourself. And if it has been over a year that you've been trying to get pregnant, do not waste any more time and go see your gynecologist, go see a specialist and tell them, I've been trying for a year. I think I need help. That's if you're under 35 years old. If you're over 35 years old, if you are trying for 6 months, waste no more time. Go to your gynecologist, find out what the issue is. Sometimes there is no issue, but find out what the issue is and either get it fixed or get the help that you need. I think that there's definitely a large disparity amongst the infertility population in terms of the Blacks or the minorities, because either we don't know to go get help or we're embarrassed to get help. And so that just wastes time. And time is something we don't have, especially if you're over 35. So I just want everyone to know that there are many people that are in your camp. You just have to reach out and say something. And it's so important to be honest with your doctor and tell them exactly what it is that you want from them, and they can guide you in the right direction. So that's my thing. I help people get pregnant.
Doctors, jump in there. I know you ladies aren't shy.
No.
Hi. Well, my name is Charletta Ayers, and I'm very proud of Dr. Gueye. I knew her as a medical student and a resident, and she was one of my scholars. I've been with Rutgers University, the Robert Wood Johnson Medical School, for over 20 years. I'm presently the vice chair of clinical services with the Department of OBGYN. I still deliver babies, and I see women also over the age of 45 as well. One of my areas of interest is really health disparities. I also am a faculty member of the School of Public Health. And I'm part of, as director of the Scholars Program from Urban Global Scholars, who are actually trying to promote individuals who in the area of women's health in the urban and global area. I do global health. My husband and I have a nonprofit where we've taken care of over 13,000 women in underserved areas, where we also see maternal health as being an issue as well. So maternal health issues and health disparities are areas of interest to me.
Hi, good evening. I'm Pamela Brug, and I kind of still do deliveries, but I'm what you call a laborist at this point, which means that I work inside of a hospital. I don't have my own patients, and cover the patients that do come in and manage their care at the time that they're in the hospital. I have been an OBGYN now for close to 30 years, and I am still on faculty as a clinical assistant professor in the Department of OBGYN at Robert Wood Johnson Medical School at Rutgers. I am the founder and the vice president of the New Jersey Black Women's Physicians Association, mainly started because of my interest in health disparities especially Black maternal mortality. These days, I live in the COVID world, and I feel like I'm an infectious disease specialist, a pulmonologist, and everything else that comes with social worker, that comes with COVID-19 and all its disparities that have been highlighted in regards to social determinants of health, which have an unbelievable impact on this public health crisis.
Thank you for that, doctors. As you can see, ladies and gentlemen, we have powerhouse ladies with us tonight. With that, I'm going to pass the mic back over to Lynn. We're going to ask our third question. And Lynn, if you don't mind, and ladies, doctors, if you don't mind, I think after Lynn's third question, I think we're going to go to our other guests that have joined us this evening, listening in to see if they have any questions for the doctors this evening. Let's give them an opportunity to really get some firsthand information from the fabulous doctors that are here tonight.
For sure. And I know we touched on this a little bit earlier, but I'd like to go more in depth. Do you see a lot of, because I know there's a high morbidity rate, do you see though a lot of maybe the discrimination cases with Black maternal health? Does that typically go into malpractice suits typically? And what can you advise? I know you're not lawyers, but what can you advise just a woman of color in general if she sees herself experiencing that sort of neglect from a doctor, or if she sees a loved one in the hospital dealing with that? Because the emotional toll of having a loved one in the hospital is, high enough. So on top of that, a malpractice suit with someone who is maybe neglecting their loved one. Can anyone speak to that?
Yeah, so discrimination, racism, bias is all around us. We live in the United States of America. It's a reality that we see not only in our patients, right, but also amongst ourselves as professionals, So the discrimination and even Dr. Ayers has discussed, the systemic racism takes a toll on Black women, in this case, as we're discussing, and their pregnancies, right? There is a certain thing, what we call weathering, right? What happens basically is, in regards to the effects of the constant impact of racism, takes a toll, leads to differentiation in regards to hormones, and then leads to certain things such as preterm labor and delivery. So you see a higher rate of preterm deliveries in Black women. And the idea is that regardless of socioeconomic class, and I want to reiterate that because we see that same phenomena in Black maternal morbidity and mortality. It's regardless of socioeconomic class, right? In New Jersey, in 2016, it was stated that Black women had 7 times greater risk of dying than a white woman, right? Didn't matter what your degree was, didn't matter what your profession was, and it didn't matter how much income you earned. Everybody knows the stories of, now her name escapes me, Serena Williams.
Serena Williams, yeah.
Everyone understands that, so it doesn't really matter. But the problems that we see, why I was saying the impact of racism and discrimination, is more having to do with how it affects us, right? When I speak to my colleagues, my children were all born premature, okay? So my first one was 32 weeks. My second one barely touched 30. And I wasn't going for the third one because I figured it was going to be like 28 or 26 weeks, right? But then I'm like, why is this happening? I have everything that I could possibly have around me. I understand And then when I speak to my friends, the same bad outcomes, poor pregnancy outcomes are noted over and over again. So I think the most important thing is actually the toll that it takes on us as women and then as pregnant women.
Dr. Brug, and I want to add to
Oh,
that. And when we're talking about the racism and the toll on maternal health, most individuals think it's the toll during the pregnancy. And many other researchers are finding that the toll is even before. The stress and the effects, the historical stress and effects from even our mothers and grandmothers onto us regarding some of the chronic medical conditions that our communities face, impacts also the health of our children and maternal health as well. Dr. Wu, thank you for bringing up weathering, because weathering is something that is now being found as to being very significant. And if you want to look that up, it's one of our colleagues who actually brought up the concept in the 80s and was poo-pooed, that it wasn't anything, until we came up again in 2000 and started looking and investigating why we had such significant maternal mortality, which was already there, but actually was then looked at another lens and said, it was being researched and why this was happening when we were seeing overall some reduction, but still in certain areas, it was still being elevated and elevated for all areas of our communities. And such as Dr. Brug shares, I also had a premature infant, my first, and I was a chief of OB services. But what my high risk factor is that I'm Black. That was my risk factor, being a Black woman. So we have to look at what our risk factors are, making sure that we have individuals who are listening to us. And again, we've heard that multitudes of times. Dr. Brug and I have been giving these talks around the state. And when we talk to women who had experiences, that the one thing that keeps coming across is, I said something, but they didn't listen. They didn't listen to my voice. And that's very disheartening, because you're seeing, I'm working on both sides of it, because I am an obstetrician, but I'm also a Black woman and also a woman who had a premature baby. So I have 3 areas here. And for someone to say, no one listened to me, that I said, I just didn't feel right. That has been really an issue. And one of the things that have come out of this, and there's also a couple of research where they actually go back and talk to women, especially women who've had negative outcomes, is that one of the things that we have to do is to listen to when women are speaking about their bodies. Women know about their bodies more than anyone else. You know about your body. Just like when Rachel said, I didn't feel really great, I'm not on my mark. She knows how she's supposed to feel. And we can't downplay that, Lynn. I think it's important for we to allow women to say, you have a right to say, I don't feel right. And I know this is not right how I'm supposed to feel. I know maybe other people maybe feel this way, but for me, this is not right for me. So I think it takes, before you get to that point, to make sure you have a provider that you have good communication with, a provider that you feel you can trust. And also there's other individuals in your health team that maybe your doctor just is really busy in not listening, but your nurses on labor and delivery are supposedly advocates. Hospitals have patient advocates as well, that you can reach out to when you're in a hospital setting. There's different ways of also getting but I think the most important is that you're making sure that not only the patient is being educated, but your health team support, if that's your significant other, husband or partner, your family member, your aunt, your sister, whoever that support person is as well, needs to also be recognized and being listened to as well, if you can't speak for yourself.
For sure.
I just want to say, I think I'm blessed that I'm a Black woman and I didn't have a premature baby. And I want everybody to know that it's not all doom and gloom. Of course, that is the focus of this talk, but there are like specific risk factors that being a Black woman increases your risk for. So if you're Black, you're higher chance of a lot of bad outcomes. And so knowing that information is really important. And I think that, and I always say knowledge is power, it's very important to know. So going into my pregnancies, I've heard all the stories from Dr. Ayers and Dr. Brug, and I'm like, oh, well, I'm definitely, these are all the terrible things that are going to happen. It doesn't have to be that way, right? If you have a good relationship with an OBGYN, if you know the things, the signs and symptoms to look for bad outcomes, and these are things that you can be acutely aware of, you have to go to every single one of your prenatal visits and make sure that you are, being heard, that your symptoms and your issues are being heard. And you also have to do things to prevent bad outcomes that are in your control. Most of it may not be, but some things are. If you are obese, then it's important in pregnancy to be normal weight. You have to work on losing weight. You have to watch your diet so that you don't become diabetic or hypertensive in the pregnancy, because we're already expecting that to happen because you're Black and you're at higher risk for those things. But if you're also not helping the fact with your behaviors, that's also not going to help matters any. Other things are, not smoking cigarettes. We know that is definitely going to increase your risk of bad outcomes. Of course, avoiding alcohol, and just being compliant and making sure that you are doing everything you can do in your power to have a good outcome. Now, whatever happens in the end, I always say we definitely have a lot of problems in the US in terms of racism and discrimination and healthcare disparities, but we have access to healthcare. So there are countries where you have a medical problem, you're pregnant, you're having an issue, no one's going to take care of you. If you don't, here, everyone, they may not take care of you well, but they're going to take care of you. And so it is definitely not perfect, but we can do our part and do the best that we can. By the time you get to your delivery, you should have established who is this OBGYN team that knows and cares about me and that understands my risks. And what are the expectations for this delivery and for this pregnancy? So I think that our healthcare system is not perfect at all, but it exists. And that is more than I can say for our brothers and sisters in Africa, in the third world, who don't have this poor access, but they have zero access. And so if you need a C-section, you can't have a C-section, you're going to die when you deliver. And that is still happening in other parts of the world. And here, at least they will take care of you. You're going to get a big bill, and these things are going to be a problem, but you're going to get care. And so let's plan our pregnancies. Let's plan our pregnancies and let's plan our deliveries and our care so that we can get better outcomes, even though we know we're at higher risk for bad outcome, no matter what you do.
Wonderful. Thank you for that, ladies. Thank you. We look like we do have a question from one of our participants that's joining us this evening. Is it Petra? Did I say that correctly?
Kitora.
Petra.
Hi.
Like I tell the other ladies, charge it to the old lady's mind, not the heart.
It's okay. Thank you for having this. Yes,
Oh, good.
just listening to all the women here. I had a difficult pregnancy, and I think my insurance company I had a good relationship with my OBGYN, but after I had Kendall, I was an older mom. I was 42 when I delivered her, and I didn't feel right. And when the nurse came to my house, she checked me. So I became the patient, and I developed post-preeclampsia, rather during the pregnancy, but I developed it afterwards. And I know during my pregnancy, I didn't feel right. So, but I think the pressure for Black women that you're thinking about, oh, well, how I'm going to pay my bills, or whatever. It's just so much pressure for us. And I like the previous speaker that she said that the system's not right, but for being one of the richest country, we should to treat all our people. Wait a minute, I'm on my earbuds. So that's what I'm saying. It's like our system, we have to be better for, no woman should die from pregnancy. So I'm just curious, is it because were rushed in the hospital that the OBGYN or don't care. I mean, they do care, but with the insurance companies, they'll tell you, well, if you have a C-section, you need to stay for 3 days. You have to get out. So just with our insurance, like I know for myself, I had a planned pregnancy. I had to get a C-section, and after the 4th day, I was out, but I didn't feel right. But overall, when the nurse came to my house, you know, I developed post-preeclampsia.
Well, I think one of the things I'm going to take that question, guys, is that I know there's something that's going across called the 4th trimester. You know, we had the 3 trimesters, the 1st trimester, 2nd trimester, 3rd trimester, and the 3rd trimester was delivery. We're now looking at 4th trimester because what you're sharing with is not uncommon. And when they're looking at regarding some of the risk, a lot of the risk of maternal issues are not normally seen during delivery. They're really seen after delivery, and we're finding that out. So one of the things that we're looking at is how can we better do that? And one is to see individuals sooner. It's something that's just recently coming out that probably will see women like a 1 to 3 weeks beforehand, even women who not only who had a section, but women who also are having vaginal deliveries. That's a change that's coming across as well. And also having community healthcare individuals being part of the team, such as doulas, social workers, and other healthcare that might not be medically driven, but can also be there to support when some woman said, certain things just aren't right. There's something that ACOG and AWAN, which is our nursing counterpart for OB nurses, came up with was the warning signs. And these warning signs are something now in the state of New Jersey that women are supposed to get copies of or being educated with at the time of delivery. Headaches, swelling that doesn't get any better, bleeding that's heavier where you're changing your pad more than once or twice in an hour for 3 hours in a row. Certain warning signs, so that giving women, such as Dr. Gueye said, knowledge that these are, instead of saying, I just don't feel right, but giving them the terms and terminology to say, I have one of these warning signs that would then trigger you being evaluated. Because many women have said the same thing you said, my friend Katora, the exact same thing, that I just didn't feel right, that I knew something wasn't quite right. And so that and empower women when you feel that way, that to be heard. So thank you for sharing your story.
Thank you
I
for
think
that.
though, besides the fact that, yes, we need to educate ourselves and understand our bodies, but I think that we also, as physicians or as other healthcare providers, we need to also work within our institutions and our health systems to address systemic racism and implicit bias. That we need to make sure that there are policies, mandatory legislation, mandatory education about this, but also that we need to have, and it is happening in New Jersey, some type of transparency about what is going on in institutions who actually are not doing the right things. And what do we need to do? Unfortunately, this is a personal feeling. I think you have to have some kind of either carrot or punitive. It's, it's not going to just say, oh, you have to do better. That's not going to work. I know that in New Jersey, in South Jersey, it's being piloted, where they are actually surveying Black women in regards to their pregnancy and their delivery and their postpartum care. And in the idea that this will become basically almost like a survey, just as we have other surveys that tell you what the C-section rate is, to be able to address this. The largest study that's actually being done about this is there's a Sacred Births. And basically what they have is a patient-reported experience measure of obstetric racism. And so they have these questions and they scale them. And basically what they're trying to see is with this scale, so it will generate a number, you know, with this scale, are they able to share this information then with the public, and then have hospitals systems address whatever those concerns are, and then continue to, you know, resurvey women to see if whatever policies are put in place, that this is actually helping. Because we have to have a way of measuring whatever we're policies or legislation that we are putting in place to address systemic racism, that we are able to measure some type of outcome. Because without it, then we don't know if it's working.
Wonderful. Thank you for that. I guess, is there anyone else who had a question for the doctors as we're getting to the top of the hour? Come on, friends. I know you normally aren't this shy. No one has a question for the doctors?
I had a quick question, if no one else from the audience. You know, women are we're taking care of everyone else in our lives. We have a high stress life, balancing work and family. What's a good way for women to sort of get in their bodies to realize that they might be having some sort of symptoms? Like, do you have any tips for how, because a lot of times most of our energy is spent mentally. So we need to get more in touch with what we're feeling in our bodies. So does anyone have any tips?
Me find me time.
Mm-hmm.
You know, I should listen to myself sometimes, but I always tell people you need to join that sorority called Me Find Me, and
Yes.
let everything else go, okay? Because I think you just need to be able to get away somehow. And it doesn't mean get away out of, just to find your quiet space to be able to do whatever it is that you want to do for yourself, to give yourself the healing mentally to start off with, so that your head isn't pounding, it's not, you know, thinking about and getting into that space. But I'm religious, so I believe in God. So I think prayer is also my form of helping myself, and being able to to feel, to have that faith that yes, you're giving it up to a higher power, and to help to lead you into a different space. And then hopefully, you are with a partner or have family members that understand when you want to be by yourself or you need that space, that they are accepting of that, and that you are not just pressured to always be the person that has to be on point.
I think I just want to answer that also. So I think the way I do it is organization, right? So I like to-do lists and I like plans. So if you know you have to get X number of tasks done, you have to know what day you need to get these tasks done, what, even to the hour or to the minute that you have to get it done. So I have 3 children. I'm running my practice in Lehigh Valley, and my husband travels all the time. So you have to understand what you can and cannot do when you need a babysitter or when when you need a break. So I schedule my breaks and I schedule all of the tasks that I have to do. And I think that as women, or especially professionals, we are used to having lots of tasks at work to accomplish. And it's like not a thing not to do it. Like you have to accomplish those tasks. So the ones for your lives, you have to treat it the same way. And when it's time for a break, you schedule that. I have to schedule my breaks. I know that doesn't sound like the ideal world, but I am more relaxed when I know my tasks are done. I cannot relax if I know the laundry's not done. I didn't have to get this kid to soccer. I have all these tasks to do. So we have a family calendar essentially, and everything to the hour is planned out. Every family member knows where they need to be, what they need to do. That relaxes me. And so the other thing is there are multiple apps for meditation. And so just taking 5 minutes, 10 minutes a day, or if you really have time, 30 minutes a day, just breathing, relaxing, listening to positive words or listening to yourself and your thoughts, that is helpful. Being around positive people. So having whoever is toxic in your life, remove them from your life, being around positive people who are moving forward with you, who are on the same page with you is a huge difference. If there's anyone that's annoying, negative, if you believe in, let's say, the vaccine, don't have friends who don't, like it's just surround yourself with positivity. And of course, all of this is not possible and depends how you are, having God, that is where it all begins for me also. And so that's what makes me believe in myself. And it gives me the strength that I need to take care of others around me, that I schedule it. Everything's scheduled. Essentially, it works for me. And then,
Okay, schedule doesn't work for me.
I know
always
it
run
doesn't.
over.
I'm very aware.
I'll be honest. I tried scheduling.
She does not organize or schedule anything. That is very true. But she gets it all done in the end, which is amazing. But it would drive me crazy. I have to have everything.
Yeah, I guess I'm not a scheduler either, and Aisha knows that as well. But I do agree that you have to be kind to yourself. Number one, you just be kind and know yourself. And I believe in affirmations and being positive. And from your health standpoint, the same way is, I think we all recommend that you have your annual exam so that you do know what is normal for you. Schedule that. That part I think you do need to schedule. You need to schedule that time for yourself of getting things. And if you're over 40, your annual mammograms. If you're, now with colonoscopies, we're finding out that you probably should be doing as African-American women sooner than age 50. Those things are important because then you're starting off with knowing what is normal. You're starting off with knowing with that clean slate. We know what do you know what your cholesterol level is? Do you know what your fasting blood sugar is? What is your normal blood pressure? Knowing those things about yourself should be similar to if you know the color of your eyes. My eyes are brown. My baseline cholesterol is this, my baseline blood pressure. And I think for our health, we are the guardians of our health, and it all starts with us. And I think if I can leave anything, just a piece of advice is for us to know what that is.
Mm-hmm.
Wow, ladies. Well, I say we're ending on an absolutely fabulous note. I'm definitely listening and paying attention because Lynn knows I'm bad. I always put too much on my plate. I always have too much going on. And even when I went to the doctor today, when they took my blood pressure, she said, "Oh, your top number's good, but your bottom number's a little high." I said, "Well, what causes that?" She says, "Well, it could have been the drive here." I said, "Oh, so I'm aggravated like that, right?" She started laughing. So, I know with me, everybody knows I always put a lot on my plate, and I have to start saying no and start, I think I'm gonna take some of Aisha's advice, which I do. I schedule everything out as well. But then you throw all the stuff in, and then the schedule goes to, hell in the handbasket, as they say. So,
Mm-hmm.
so with that being said, thank you so much, doctors, for your time tonight. It is greatly appreciate it. And I know everyone listening greatly appreciated all the information, all the advice. Lynn, was there anything that you wanted to say or leave with the doctors?
No, I was just gonna say I was gonna start scheduling my wine breaks now. I'll feel less guilty. No, no, it's just so important for us to just, practice self-care. And so thank you to our doctors on our panel tonight for informing us. And I hope the ladies at home, take action today, get your visits in, make time for yourself, prioritize your health is so important.
Absolutely. Well said, my partner in crime. So with that being said, doctors, we are humbled and gracious that you joined us
Thank you
this
very much.
evening.
Thanks for
Thank
having
you
us.
so much.
Thank you.
Definitely will have to, of course, do this again, as I know we move into the summer and all the other wonderful dialogues and issues that we can discuss. And with that being said, from Women of Color Coalition, we're going to say good night. And I want to thank everyone for joining us this evening. And please keep in touch. Check us out on our website, womenofcolor.com, as well as Facebook and all our social media locations. And also with the doctors. Dr. Proctor, is all the ladies part of your New Jersey Black Doctors Association?
Yes.
So definitely everyone, check that out if you're looking for with telehealth. I love the telehealth because now you can pick your doctor from anywhere you want to now.
Yes.
Definitely check these ladies out on their website. Ladies, did you want to leave your website or any of your information or upcoming events before we go?
Oh, sure. I would say that tomorrow we're having a discussion about Momnibus, which is important federal legislation in regards to addressing maternal health equity. It's a discussion with Senator Cory Booker, who is a sponsor, and then followed by a panel discussion of distinguished women in regards to that policy. And then we will continue through the month of May with different panels. So please look at our New Jersey Black Women's Physicians Association website or follow us on Instagram, Twitter, Facebook.
I love it.
They got all the social media.
Yes. Do you ladies have a link to drop in the chat?
Yes, I will put it in our website, and please feel free to join us.
Oh, definitely. And you know what, ladies, send us that information because we definitely will get that out on our, in our social media sites as well. And, keep pushing it around for you as well, to let everybody know about the event.
Oh,
Definitely, please do.
we definitely appreciate it.
Oh, no, definitely.
Hey, Kathy.
It's much needed information.
Yes, next time, Lynn, the wine.
Yes.
Yeah, right.
Absolutely. Oh, a little tip, my husband makes homemade wine.
Oh, well, we're all going to Rachel's house.
Yeah,
We'll
head
go
over to
outside with
Jersey.
socially distance.
His new thing now is, I think that's what keeps, well, first of all, it's not good for my waistline, but hey, oh well. So between the wine, he makes homemade ice cream. He does it all. So he's keeping his girl happy over here between the wine and the ice cream.
Nice.
Well, I will not keep you fabulous busy ladies any longer. And with that being said, good night, everyone. And thank you for joining us.
Bye.
Thank you so much
very
again.
much.
Bye-bye.
Thank you. Bye-bye.
Bye.